Well, welcome everyone. We're very excited to be here. Michelle, do you want to sort of take the lead on this and introduce yourself, and I can quickly introduce myself? Yeah.
Absolutely. I'm so excited to be here, Brian, with you and for the CLL Society and our patient community for this first ever Facebook Live event for the CLL Society and Ask Me Anything. And I'm so excited to be here and hoping people will send in their questions to us to ask us anything. So I'm Michele Nadeem-Baker, for those of you who don't know who I am, and I'm a CLL patient advocate, and a medical journalist. And many of our viewers may recognize me from some of my patient power programs or on our Facebook CLL support groups that we all participate in. And in some of the CLL communities I've co-founded, like CLL Women Strong and Kicking Cancer in Heels. And those are on Instagram and Facebook if you want to follow those. Brian?
Thank you, Michelle, and it's a pleasure to be doing this with you. I'm Dr. Brian Koffman. I'm a retired family doctor and a CLL patient myself for 17 years. I'm also the co-founder with my wife, Patty, of the nonprofit CLL Society, and where I now serve as the executive vice president and chief medical officer. And I think most of you know about us, but the CLL Society is founded to meet the unmet needs of the CLL community. We're laser focused on CLL and SLL, and really that's where we do our 4 areas of work, which are support. We have 40 support groups across the country that meet on a regular basis. We have information on that on the website. Education, and this is one example. Then we have webinars at least once a month that we do, plus all kinds of new research, hundreds of articles published every year on the latest in CLL. Research, we're excited. We published papers about what's important to patients at the American Society of Hematology, ASH, and ASCO, and EHA, and all the major meetings. And now we're starting to actually fund bench science and translational research on the unanswered questions in CLL, because too often people see CLL as a solved problem. And the last area is advocacy. And what we've always done what I call small a advocacy, which is advocating on behalf of single patients, teaching how to be your best advocate in the doctor's office or with your insurance company. We've done more big A advocacy in terms of issues of making sure the immunocompromised are not neglected during the pandemic, looking at drug approval processes, looking at the design of clinical trials. So we're talking with the FDA and the CDC and in other branches in the NIH on a constant basis, attending congressional subcommittees, trying to represent the needs of the CLL community. So I'm very excited because this is essentially our first Facebook Live event. But yeah, so I'm going to hand it to you, Michelle, because you're the one who has more experience on Facebook Live. So I'm excited to be doing this.
I am too. And, I was trying to remember when we first met, Brian. We've met in person a bunch of times, but I think the first time was at the CLL Society meeting here in the Boston area, where I met you a few times at those, one of the 40 groups that the CLL Society has that currently meet virtually, at least here. And then also at ASH, we ran into each other. So it's, and I think probably it's been maybe 3 or 4 years since we have met. So this is great. This is really wonderful to be here. And I know that we're going to talk about when we were diagnosed and how long we've had CLL. And, I was diagnosed back in 2012. So I realized 10 years now. And, I had already had fatigue, but I didn't think anything about it because I was working, almost 24/7, truly, only getting a few hours of sleep a night because of my career, which was a global job. But when I was diagnosed, it was delivered to me in such a way, like, you have the C word, the best kind, and there was no information back then that the doctor could give me to explain it. I'm sure some of the people here who were diagnosed years ago couldn't find anything. I couldn't find anything credible, short of pulling all my, root canals out or fillings or getting, or, other doing crazy things. So basically I vowed, because my career has been in journalism and communications, that someday I wanted to change information to the way patients got it and received it. So there was information, it was patient friendly. And I started that my first day of treatment, my frontline treatment, which was the clinical trial IFCR, ibrutinib and FCR. And I started to try right then, demystifying and explaining in patient-friendly terms what the patient experience. Fast forward, I was on that trial until 2019, and I remained progression-free for 2.5 years. I know, it's pretty great. 3.5 would be better, but 2.5, I'm taking it. And I relapsed this past fall, and I'm back on treatment, and I'm on acalabrutinib and doing really well. What about your journey, Brian?
Well, I was diagnosed in 2005. So if in 2005, CLL, there were no options. There was no treatments that were shown to even prolong life. So I was diagnosed with this incurable cancer, which no therapies at that point had been shown to even add a minute to your life. So you could get treatment to knock the cancer back, so you would live better until you died, but you'd still die at the same time as if you hadn't had treatment. There was just no good treatments. I noticed some lumps on the back of my neck, and they say the doctor who treats himself as a fool for a patient. I ordered some blood work on myself. My lymphocyte counts were elevated, and pretty soon I had a test called flow cytometry, which looks at the type of lymphocyte that was elevated, and they were clonal, and it was CLL. And I remember my hematologist, I didn't have a hematologist, but the hematologist that I consulted saying, yeah, you've got CLL. And with me, it wasn't, I hate when people say you've got the good cancer. The word good and cancer should never be in the same sentence,
Exactly.
But the expectation as a physician was, well, you know all about this. Well, the reality is, a family doctor, about less than one, I write my board exams, less than 1% of my exams are on hematology, and most of that's non-cancerous, benign hematology. So it's not a big area. Most family docs are scared of hematology and send it to a hematologist when somebody has an abnormal count. So I had to scurry like you to become more expert in this. And what I found was really depressing, and there wasn't a lot of information. I had a very rocky course. I developed a complication, an autoimmune complication, where I killed off my own platelets. That's called autoimmune, an autoimmune complication called immune thrombocytopenic purpura, or ITP. I had multiple hospitalizations. I had to have my spleen removed in an emergency situation. I bled internally. My hemoglobin, my blood count dropped by half. I was in bad shape. It's very hard to get my platelets back up. I was constantly bruising and bleeding. And I ended up finally getting to remission with a combination of a drug that was being used to treat my ITP to suppress my immune system, and rituximab, which is a monoclonal antibody that's used to treat CLL, but also autoimmune conditions, like it's used for rheumatoid arthritis and other diseases. And that combination not only controlled my ITP, my autoimmune problem, but my CLL. I went on to a transplant. It didn't work. And I started to tell my story, and I was emailing everybody, and my kids said, Dad, that's so old school, email, you should be blogging on this, So I started a blog, and the blog became extremely, popular. And I had a background. I have not only am I a medical doctor, but I have a master's degree in medical education and taught medical students. So I worked with a med ed company. So I started to teach about it. And then I kind of leveraged that to get to know a lot of the doctors and started to attend ASH. And like you, I think I was one of the very few patients who would go to these meetings. I mean, there could be 20,000 people at these meetings and maybe 10 patients, I think would be a realistic number, maybe 24 patients at the most. I mean, there just weren't a lot of patients at these meetings. They weren't set up for patients. But I started to go to the meetings and leverage, my education background. And it became clear that the blog, which told the story chronologically, wasn't the way to go. So my wife and I founded the nonprofit CLL Society to tell that story. And the story I ended up telling was jumping into a phase 1 trial of PCI 32765, which later became ibrutinib or Imbruvica. And so I was one of the first, maybe less than 200 people in the world had taken it when I started on it. And it was still very experimental, very exciting. I remember going to ASH and there was this buzz about these new drugs. One was called Cal 101, which later became idelalisib, and the other is PCI 32765. People were really excited about these drugs. And they said, and they're working on people with 17p deletion, which is a bad prognostic marker, which I had, and 11q, and ZAP70 and CD38 and Notch1, all these terrible markers. It just, things did not look good for me. And then there was all this buzz, but we have this new targeted oral therapy. And so I remember meeting Dr. John Bird in the hall at ASH, and he said, I've got this trial going. You know, it's in Columbus, Ohio. And he penciled me in for it. I remember our friend Andrew Shore introduced me to John, and it was, yeah, I met him in the hall, and then I ended up flying out there and jumping in that trial, and I got 7 years out of that trial. One of the very early, I'm a very early adopter of new trials. I finally relapsed on that and went on to JCAR014, which is a CAR T, a cellular therapy, still experimental in CLL, but it's the grandparent of Liza-cel, which should hopefully be approved, hopefully next year, a very active cellular therapy, and I'm 4+ years out from that. The other trial that I'd been in, just to share, is I was on an AZD7442 trial, which later became Evusheld, which, and I was lucky to be randomized into the active arm of that. And we all know, and I know there's a lot of questions about Evusheld, but we know the important role that Evusheld is playing in protecting us with the compromised immunity during the pandemic. So I am alive today because of the principles of getting experts involved in my care, enrolling in clinical trials, and leaning towards the novel targeted therapies, and in most cases away from chemoimmunotherapy, unless it's part of a clinical trial or in combination with a targeted therapy, as was in your case. So that's my story, 17 years and still going.
Wow, that is fabulous. And thank you so much for being on those clinical trials to help the rest of us. You know, I'd be on a clinical trial again now if there had been an open one for someone who is relapsed, that was open at the time, that, you know, if all the stars had aligned. And it's very interesting because I was really happy to be on a clinical trial, because not only are you helping other patients, but you're getting potentially tomorrow's treatment today, like you did, things that were approved. And you were, as you said, an early adopter. So, you know, we have so many questions. I have to tell you, they keep coming in. Maybe we should jump to those right now.
Right.
And, you
so
know,
I'll just,
and we have people from all over.
I'm just going to go with the official disclaimer to remind people that we are not giving medical advice here. We're telling our stories. And even though I'm a physician, I'm telling my story as a patient here. And any things that we say, any suggestions or comments, they should be run by your treatment team to make sure that they're appropriate for you. We are not trying to give you medical advice or in any way displace the opinion of your treating physicians. This is Facebook. This isn't a clinic. So please keep that in mind.
Please do. You know, we have so many questions that have come in about COVID and Evusheld because of our situation, I'm sure, as CLL patients. So let's start with those. There have been a lot of questions about the role and timing of COVID-19 boosters and Evusheld. You know, how long do you wait in between? How how much before. Can you offer any advice? And wow, and we have new latest recommendations that can be shared.
Yeah. So this is extremely confusing, and I pay attention to some of the chat rooms and the message boards and the Facebook groups, and there's conflicting opinions, and there's conflicting opinions from experts. But I'm going to just read you, and this is from the CDC website. Okay. COVID-19 vaccinations can be given at any interval following the receipt of a passive antibody therapy. So Evusheld is a passive antibody therapy. So according to the CDC, you do not have to wait. Now, if you want to wait a couple weeks, because if you just got Evusheld, you're probably pretty well protected. There's no harm in waiting, but according to their guidelines, you don't have to wait. What about the other directions? This is, again, their guidelines. Patients should wait 2 weeks after COVID vaccinations before receiving Evusheld for pre-exposure prophylaxis. Now, I'm going to tell you the truth on this. The truth is we have very few data points on this. There's very little data informing us. We have non-human primate data that suggests that it's okay to take the two together. We have some patients who got other antibodies because they were sick and then got vaccinated and did just fine and responded to the vaccines. But there really aren't any really good studies on this answering these questions. So it's kind of the best opinion that's out there, and different doctors are going to have different opinions on this, but that's what the guidelines are right now, and those are accessible on the CDC website.
Here's another with COVID. We hear about new COVID-19 vaccines being developed. Are there any that target helping immunocompromised patients like those of us with CLL?
Yeah, great question. And the answer is yes, they are in development. And there are clinical trials that are starting right now. And there's actually some clinical trials that are going on. And what they're trying to do is tweak the T cells more. So there's two parts to the immune system. There's the liquid or humoral immune system, which is the antibodies, and that's made by the B cells, and CLL is a cancer of the B cells. But so we don't form antibodies very well. And if you've had a medication like rituximab or obinutuzumab Gazyva, that really knocks out your ability because it kills off not just the CLL cells, but also the healthy B cells. So it really diminishes our ability to form antibodies. In CLL, our T cell function isn't great either because the B cells don't want to be discovered by the soldiers of the immune system. So the T cells tend to have this exhausted kind of wimpy profile. They don't do a very good job. But there are developing new vaccines that are specific for the immunocompromised that will be helpful. So some of these have been presented. There's early data on them that's encouraging, but they are not out for commercial use. And there should be some trials coming up soon that we're going to be publishing on the CLL Society website.
Looking forward to reading those because that's something I'm interested in, everyone else is interested in. We have a few more questions on this and then we'll get to some others. So someone here is asking about when the newer vaccines come out, if they should wait, they're due for their booster shot now, and they're asking if they should wait until the fall when the newer vaccine is shown to better protect against Omicron, but we don't know fall definitively.
Yeah,
right?
I've heard October, but things keep getting pushed back, and I think that it makes sense to get vaccinated when you need to be vaccinated, and it's based on everything that we've seen. Likely, if you get a vaccine in July or August, if you're due now, it'll be fine to get one again in October. It is a different booster. I just wouldn't count on October because October could slip till February, just based on what's happened. the government, there's been funding issues, there's been availability issues. It's none of this is for certain. So I would get into my arm, whatever I could get into my arm when it's available. I mean, that's certainly my plan.
Someone else has asked more information on Evusheld and if this is able to protect against the newer variants like BA.5.
Yes.
This particular person, Mary, is heading to a family reunion with 60 family members and a lot of little kids who are unvaccinated. And but she said most events will be outside. What do you think about that?
So I think there's two questions there. The data that we have on Evusheld protecting against BA.5, which is now the dominant variant, and what we know about it is the most contagious variant. And most of the people that I talk to, and I don't know if this is your experience too, Michele, is I've never had so many friends who had COVID as I do today. I mean, it's just everybody who's out in the world has COVID. That it seems, that's an exaggeration, but there's so much COVID out there right now. It's extraordinarily contagious. Whether it's more virulent or not is still up in the air. It is certainly not less virulent than Omicron. And though the recent data from out of Scandinavia has shown that our mortality rate with Omicron is much lower than it was early on, much, much lower. We think that's two reasons: that Omicron tends to stay more up in the upper airways and doesn't seem to involve the lungs as much. So you don't get the shortness of breath, you don't need to be hospitalized. And the other thing is that even if we don't respond to the vaccines with our antibodies shooting up, we may be having some T cell response. We may be having some other benefits from it. So we think a combination of these two things is offering protection. So we're not seeing nearly the mortality that we used to see that was so dismal. So then getting to the question, does the Evusheld work? So the pseudovirus tests, and these are where they make kind of fake viruses, as the name implies, says that it does work against BA.4 and BA.5. Doesn't work as well. You need higher doses, but that's still under the curve, under the area of protection that you get for that 6 months of Evusheld. What we don't have is live virus data yet. And I want to see that to be 100% certain, because I think that data is more reliable. But generally, both the company who manufactures AstraZeneca and the CDC have both said that it continues to work against all the variants of concern, including BA.4 and BA.5. So I'd like to see the live data, but at this point, I'm feeling pretty comfortable. Now, the next question is, do you go to an outdoor party with 60 people, and there is definitely a risk. This is so contagious that there's definitely a risk. And if there's kids running around and people aren't masked, then you have a risk. If you're going to wear an N95 mask that fits you well, and you're going to socially distance, and you're going to eat away from everybody else when you take that mask off, then I think that your chances of getting COVID are markedly diminished. But there's still a chance, even under those circumstances, you could get it. And I think you just have to look at what the risks are. I mean, and you only get each day once, you only get these family reunions. What risks are you willing to take? And I think now, with the COVID generally being milder, and with the treatments that we have, like Paxlovid and Bebtelovimab, and remdesivir, we have really good treatments for COVID infections and CLL patients. That maybe it is worth taking that risk. Everybody has to make a decision. If you are waiting for it to be 100% safe, I don't think we're ever getting there. I think the sad reality is, and I think we're all waking up to this, is that COVID isn't going anywhere. It's still going to be here. So at some point, you're going to have to go into the water again, even though there's still sharks out there. So what risks are you willing to take? Calculate them, do what you can to minimize them, and make a decision. Is this worth taking the risk? You know, I wouldn't go to a big concert or an indoor sporting event, you know, where everybody's screaming and not wearing a mask. Even with a mask on myself, I wouldn't feel comfortable doing that. But I know people are doing it and not getting COVID. So, I mean, you have to make your own decisions about what risks you're willing to take. A family reunion, I think that might be worth a little bit higher risk profile. Yeah.
And a family reunion outside, but still taking all the precautions you were
Right.
saying. Glad I didn't hear this a week ago, because I went to one last Friday outside and I wore my mask on and off, but still, I may not have gone if we had had this conversation a week ago. So let's take one last question. Oh, actually, we have a couple more questions here. We have so many on this. Some of my family, all vaccinated and boosted, have had COVID this year. They've now recovered. They've quarantined for 10 days. They're out living their lives again. They're going to gatherings, traveling. If someone's already had COVID and recovered, then comes into contact with someone else that has COVID, can they become infected even though they have antibodies from having had COVID recently?
The answer to that is real easy. Yes, absolutely, unequivocally. People have had COVID twice in a month. I mean, the antibodies from one variant, this is called immune escape, BA4 and BA5 are good with this. The vaccines are less protective against these. You're really using Evusheld for your protection. So absolutely, we used to think that if you had COVID, it was protective, and it is protective to some extent. And the people that have the mildest cases of COVID are the ones who've had a prior infection and are vaccinated. Does it protect against those people being hospitalized? Yes. Does it protect against them dying? Yes. Does it protect them from getting COVID? No. Does it protect them from giving you COVID? No. I'm just going to answer two other questions that I'm kind of looking through here. If you're on watch and wait, should you get Evusheld vaccine? I think the majority opinion is that you should. Not every doctor agrees with that. I think every CLL patient is immunocompromised. If you're in treatment, if you're not in treatment, if you're in complete remission, every CLL patient is immunocompromised. And I think all of us should get Evusheld, especially because the vaccines are hobbling at this point in terms of the new circumstances with the new variants. The other question is the second Evusheld dose. That's one that's very new, just came out the end of June. And that's 6 months after your last dose. So if you're a person like me who got half a dose in January, half a dose in March, then you're supposed to wait 6 months from the March dose to get your second Evusheld dose. I don't think you're breaking any laws if you get it a couple weeks early or a couple weeks late. We don't really know. They're kind of making this up as they go along, but it has a very long half-life, and it all depends not so much on the blood level of Evusheld, which is still quite high at 6 months and very protective of what's here now. It's what's coming next. You know, that's the concern. We don't know what's next. So will that dose work? I mean, we know that the half-life of REGEN-COV, you know, gives you 3 months worth of protection, but if it doesn't work against the variant, it gives you 0 months of protection. So that's the unknown in this. At this point, Evusheld is still doing well and still protecting us for 6 months. So I would start thinking about that second dose for people. And that's probably in the fall for most people.
And with the new, we have another question. With the new vaccine coming out and it's going to be more protective against the other variants, do you suggest that patients still get Evusheld once they get this other vaccine?
So I'm a big believer this is personal, this again, not medical advice, and talk with your own physician, but I'm kind of a belt and suspenders kind of guy. COVID is not your friend, okay? You want to make sure that you're as well protected as you can be. So I think that if there's a new vaccine that offers a higher level of protection, then you should get that vaccine, because it boosts the whole immune system, a vaccine. It tweaks your immune system. Now, CLL patients may not respond very well to that vaccine, and we know that we're cause more breakthrough infections in people who've been vaccinated. So I think you should also get Evusheld. I think you should do both if you can, if you're in a circumstance where you can do both. If you respond to the vaccine, that's probably bluntly better than Evusheld, because it's a broader response. But we don't know what that response really means, and we can't really measure, and measuring T cell function can be done, but it's an expensive and not generally available test. So I'm a big believer in doing both. That's what I plan to do. Personally, I plan to get vaccinated and then wait the 2 weeks, because it just makes sense to me that I'm going to do better. It just seems like a more logical thing. Get the vaccine, form the antibodies, get the T cells going, so the Evusheld doesn't blunt a response to that. It just seems that makes more sense to me, though I have no data to back that up.
Good stuff here. There are a few more in Evusheld. Someone's asking about side effects from Evusheld. Is a swollen tongue a side effect? I thought I had seen another one in here.
The most common side effect I see from people is fatigue. People feel lousy afterwards, sometimes, but it's usually very mild. Some people get a headache. Some people are sore. It's a drop your drawers shot. So it's a big shot into the buttocks, on both sides of the buttocks. So it's not in your arm. Some people get sore, need to sleep it off a little bit. But generally, there haven't been much adverse events with it. Now, there have been people who felt lousy with it, and I think anything is possible, but it's extremely rare to have adverse. For me, it was a non-event. When I got my AZD7442 in the clinical trial, I thought I'd gotten placebo, because it was nothing. It was just, I thought, oh, I got the salt water, because it didn't hurt. I didn't feel anything. I thought, darn, I got randomized to the salt water. And I found out later that I didn't. So I think that's the case for most people. It is much less than the vaccine, because the vaccine is active immunity. It's sending something into your body saying, we want you to make antibodies, so if the real thing comes along, you can fight it off. So it's charging the whole immune system, and it's like I say, teaching your body to fish. It's making you learn how to do something. So it's revving up the immune system, and it's causing kind of a little bit of an inflammation. And that's why people get fever, achy, feel crappy, because your immune system is on charge. Evusheld is passive immunity. It's giving you somebody else's antibody who's done a great job of killing off Evusheld, neutralizing Evusheld. So it just puts a whole bunch of this in there, and your body says, thank you, and it doesn't have to do anything. It's giving you 6 months worth of cooked fish meals, so you never have to go fishing. So there's no major inflammation or anything from it. So it doesn't cause the same kinds of issues. People asked about flying. Again, I think it's why flying is a risk. But I think if you wear an N95, when I fly, I wear an N95 mask. I drink water, but I have a flexible straw that goes up and under my mask and in my mouth. I don't eat on the plane. I don't eat at the airport. I'm pretty hungry when I get to where I'm getting, but that's what I do. And I've flown successfully, and a lot of people have, but I've also heard people catch it. The airport is pretty high risk itself, and you should be wearing a mask in the airport. But again, it's like public transit, I think, is a significant risk for a lot of people. And I'll just comment on one other thing, the distribution. There was something here about teaching hospitals and
Yeah, getting Evusheld.
Evusheld, the distribution has been problematic for sure. So we have resources on our website about where you can find it and look around. Often you have to, at the teaching hospitals, some of them have had very low supplies, so they're prioritizing their most vulnerable patients. And while we're considered among the vulnerable, we may not be the most vulnerable, like somebody's had a lung transplant or a recent bone marrow transplant. So we may not make the cut of the supply that they have. So you have to look around, but often if you go to more community hospitals, they may have gotten less Evusheld, but they may have more of it sitting around to get. So you really have to be clever in terms of finding out how to get it. We have lists, there's supplies available where you can look, you can call ahead and get your doctors to order it. But if you're a CLL patient, you qualify to get Evusheld, and you have to, sometimes you have to make a little bit of a fuss because the language says, including but not limited to blood cancers and active therapy. And we're not, if you're not in active therapy, they say, well, you don't qualify, but it says included but not limited to. And so we've been working with the CDC and the FDA to change that language, but it's not been easy to make that change. So it's more clearly understood, but we absolutely qualify. And if you can't find it at one place, you can find it other places. I ended up getting it at my community hospital and not from my hematologist, but my family doctor was able to get it for me. So it's, you just got to be resourceful.
That's for sure. I mean, a lot of patients I know have been so resourceful. Some have traveled between states or found other people where they've gotten it and it's been easier to get it. And it's just, it may take time depending on where you live to find a place, but it does eventually pay off, but it should be so much easier. We've had so many questions about CLL patients, if they're on a BTK inhibitor like ibrutinib or acalabrutinib, zanubrutinib, what happens if they get COVID? Should they go off of it? Others about the different monoclonal antibodies like Paxlovid and people, is it okay to receive that? Some are being told they're not at risk and they don't need it, even though they have CLL.
So Paxlovid is an antiviral. It's not an antibody. Beptilovimab and Evusheld are antibody or combinations of antibodies. So the decision about medications, if you come down with COVID, is one that has to be individualized, and you have to talk with your hematologist. It's very different coming off ibrutinib or acalabrutinib. If you've been on it for 3 years and your disease is really well controlled, you have very little disease, versus if you've been off of it for a couple months. And sometimes there's been patients who go off their disease and their disease gallops away until they get back on the medicine. So that's an individual decision. Generally, most doctors would hold antibodies because antibodies are immunosuppressive and there's not this issue of the disease galloping away. So if you came down with COVID and you're due for your next obinutuzumab Gazyva shot, they'd probably say, nah, probably not a great idea if you're dealing with COVID right now. Let's hold off on it. Though, again, an individual decision. The same with venetoclax. Most docs would hold that if you had the COVID because it can be mildly immunosuppressive in some ways. So the BTK is a more complicated issue. There are drug-to-drug interactions with Paxlovid that complicate its therapy. So if you go on Paxlovid, you may have to come off your BTK inhibitor. And so that is a decision that has to be made between you and your physician. That may be a case where you would prefer to get beptilovimab if you can, which is an antibody, so you don't have to come off, or go on remdesivir, or for a lot of people, it's fine to go off of ibrutinib or acalabrutinib or zanubrutinib for 5 days. It won't make any, you can go off the day before, or even half a day before you start the Paxlovid, and then go back on it a day after you stop. It's not like you got to stay off of it for weeks. So that would be a decision that you would make with your doctor. It really upsets me when I hear that people are being refused Paxlovid who have CLL. These doctors don't know that you are immunocompromised. It's a cancer of the immune system, and you are much higher risk. And even though our mortality rate is now in single digits compared to what it was before, it's still 10 times at least 10 times higher than the general population with who get COVID. I mean, isn't that, I mean, do we have to have a 30% death rate like we had at the beginning to, to qualify to get these drugs? I mean, it just makes no sense to me. And what I've seen people have to do is have to go around their doc and find a different doc. I think it was yesterday, there was approval, ASPR, the Assistant Secretary for Preparedness and Emergency Response, has been fighting to allow pharmacists to prescribe it. And the pharmacists now, if you walk in and you show them your test with the blue bar, that says you're either you're pregnant or you have COVID, one of the two. If you have the COVID and you have CLL, you can now get it from a pharmacist and bypass your physician if your physician is giving you a hard time. And the test to treat centers are available. And again, we have a list of those. And Paxlovid is pretty well supplied right now, unlike Evusheld. It's pretty easy right now to get Paxlovid, is what I'm hearing. It's not a supply issue. Sometimes it's a doctor knowledge issue.
So here's our bridge question to bridge us into other areas. We just have
can we talk about CLL a little bit? Yeah.
I know we could have like 3 hours, I think, on all of this, because everyone wants to know. I think bottom line is we all want to have a normal life, right? Moving forward.
Right. And our lives were pretty normal, weren't they? Until, for most of us, most of your life is pretty normal until the pandemic. I mean, I was traveling, you were traveling, we were doing all of this stuff. But until you actually need treatment, when you're in treatment or the pandemic, my life was pretty normal. It was just kind of an annoying background thing,
And even, for me, on most of my time in treatment before, other than the first 6 months, I did everything, as So it really has put a crimp in our lifestyles. Okay, here's our bridge question. So if a CLL patient has completed a fixed duration treatment and has achieved MRD negativity, will their immune system then be considered normal, or are they still immunocompromised?
Great question. So there is clear evidence that the more disease you have, the more compromised your immune system. It's not a one-to-one correlation. And as my case pointed out, it's not just that your immune function is disabled, it's dysfunctional. So mine was attacking my platelets. Other people, it attacks their eyes. Other people, it attacks their red blood cells. They become anemic. People get gut issues. I mean, they're rare, but you get these autoimmune conditions with CLL. But as your disease gets less and less, your likelihood of having these autoimmune problems is less, and your likelihood of being your degree of immunosuppression is less. And for example, with ibrutinib, people who take ibrutinib, there's a much higher incidence of infections in the first year than in following years. And we don't think that suddenly the ibrutinib has a change in its chemical structure. We think it's because the ibrutinib has shrunk down the amount of cancer that you have. So you have less CLL. So because you have less CLL, you have a better immune system. Your immune system can respond to infections. So you get less infections as you get further and further out. That said, it is extremely unlikely that your immune system is going to be back to that of your cousin's immune system who doesn't have CLL. Everybody who has CLL. So when we look, for example, at antibody responses to the vaccine, which is just one part of the immune system, but we see who does well and who doesn't do well. So people who on ibrutinib don't do well. People who are on obinutuzumab and rituximab do terribly in terms of forming antibodies. People on VAN tend not to do well. People on chemotherapy do awful. People who are a year out from some of these treatments, especially the antibodies, still don't do well. People do better who are in a deep remission and do better if they're in watch and wait or active observation, but they still don't have a normal immune system. And still a significant percentage of them don't form antibodies, even people who've never had any treatment. Even with the precursor to CLL called monoclonal B-cell lymphocytosis, or MBL, even those people who don't even have a cancer still have an impaired immune system and don't respond as well to the vaccines. And we've known that. And it's not just the COVID vaccine, it's the pneumonia vaccine, it's the shingles vaccine, it's all vaccines. We don't respond well. So if you're treatment naive, if you're in deep remission, you're going to have issues. The one exception may be people who've had a bone marrow transplant, a successful bone marrow transplant. They've gotten rid of their immune system and imported somebody else's that's wiped out their cancer, and they've developed a whole new immune system. And those people may be more immunoprotected, not immediately, but maybe after 3 to 5 years if they've had a successful transplant. So that's the one exception. But it's better, UMRD, you're in much better shape than the person who isn't UMRD.
Okay, well, here we go. That brings us to a few other questions with that statement.
Okay.
So, Teresa here gave us a little background. She'd asked her doctor to change treatments from ibrutinib after she completed a clinical trial to acalabrutinib based on the data from ASCO, from the Elevate trial for relapse. Her question is should she still try to get that UMRD status with a combo treatment versus continuing with Calquence? Okay. Her doctor does not seem to be as excited about reaching UMRD. What do you think about UMRD versus just having progression-free survival? We've had some other questions I'm trying to combine all here.
Okay. So I'm just going to respond to somebody who said about SLL, and just to say, and I know you feel like the poor stepsister here, when you're SLL, but everything that we say about CLL applies to SLL. Everything. So there's less, the way the FDA sets it up is you have to do CLL research and SLL research, and they separate it, and they really should be combined, but it's a whole other issue. And there's fewer people with SLL, that's why you hear less about it. But everything we say about CLL applies. Every drug, every therapy, every immuno issue, every COVID issue, all applies the same. And I know at the CLL Society, we actually rewrote our mission statement to include SLL. So I know what you're feeling. So
we have one more SLL question while you're there. So
sure.
Can I just say that? Okay. Please. Lynn Bailey, is it appropriate to follow SLL patients with CAT scans since the disease progression is not apparent in blood tests?
So the guidelines from the NCCN and IWCLL are pretty clear on this, that there's no role for routine CT scans unless there's a reason for them. So if you're feeling abdominal bloating, distension, you're having pain somewhere, your kidney isn't functioning, you better see if there's a lymph node causing the problem, pinching against something. Is your spleen massively enlarged and pushing into your stomach so you can't eat correctly? Absolutely, you need imaging to do that. I like MRIs myself They're longer, they're more expensive, but there's no ionizing radiation. And we already have, and we know that too much radiation causes cancer, causes lymphomas, and over 5 CT scans is probably, which is real easy to do in CLL, to get over 5 CT scans, is associated with a higher lifetime risk of lymphomas. So unless there are, when you're in a clinical trial, or if you're on therapy and they want to see if the therapy is working, then of course they've got to do a CT scan to see if the glands are shrinking. But you can also tell a lot by just feeling the neck and the armpits and the groin and examining the lymph nodes. So I think CTs tend to get overused, but certainly following disease when it's on treatment, following when you're in a clinical trial, if you're symptomatic. But if your nodes are enlarging, but they're not causing you any problems, then why say, okay, it was 3 centimeters, now it's 3.5 centimeters, or it's 4 centimeters. So you're not going to treat it because of that. You're going to treat it because you feel like crap, you have fever, night sweats, unexplained weight loss, it's causing you pain, then you're going to treat it. So knowing the size of the nodes. Now, you're on a therapy, is it working? And you don't have palpable nodes. I got to see if that huge node that was pushing, in your liver area is shrunk, then absolutely get a CT scan.
Okay. Oh, let's get back to the UMRD. Is UMRD, is that as a goal? Should that be, this is one, or is it progression-free survival?
So the ultimate goal is to live as long as possible, as healthy a life as possible. So overall survival is your ultimate goal. And I think a secondary goal is progression-free survival. Now, we know that with certain treatments, people who reach undetectable, measurable residual disease, I like to call it measurable rather than minimal residual disease, because there's still disease there. This is not necessarily a cure. It could be a functional cure. The disease could be so low that it's going to take 20 years before it shows up again, and you're going to be 110 at that point, so it doesn't matter. But and we do know that people who reach UMRD tend to have more durable responses and better overall survival. But we also know that people who take a BTK inhibitor frontline have fabulous overall survival and fabulous progression-free survival. And most of those people do not reach UMRD. So one of the unanswered questions that this patient is very astutely asking is, what's the right thing to do? I'm 7 years out on ibrutinib, or 5 years out on acalabrutinib. I'm doing great. I still have this low level of disease. Continue business as usual, or should I add a second medicine to see if I can get to UMRD and get off of it? This is uncharted territory. We don't know the answers to this. These are trials that are going on. The Germans are doing trials on this. What's the best treatment on front? Is it to do fixed duration, do venetoclax and obinutuzumab? Is it to do ibrutinib and venetoclax and do those and stop and glide and then retreat? There's a lot of, people don't like being on treatment. All treatments have side effects. Some of those side effects can be financial too. So is it better to treat multiple times and have rest periods in between? Is it better to be on continuous therapy? I think most people, if they had a choice and they were equally effective, we can give you a drug for 1 year, we can give you a drug for 7 years, but you're going to live the same length of time, would prefer to take the drug for 1 year. We don't know yet if you're going to live the same length of time with those therapies. So those are unanswered questions, but they're being actively answered right now. So, and you're going to get very different advice from different doctors on this. It's very different CLL because it's not like if you go to a doctor and you have a strep throat, you get penicillin. It's not like a discussion. If you're not allergic to penicillin, you get penicillin. It's not like, what's the best treatment? What should we do? Should we try this? And it's penicillin. But in CLL, every stage of the way, well, we could do this, or maybe we'll do that, or we'll do a combination of this. And, and you see 3 doctors, you get 5 opinions.
If someone first time out has an average time to relapse.
Mhm.
Is that, let's just pick a number, 3 years. Is that necessarily going to be the same time of relapse, until relapse after each line of treatment in the future?
Another good question, and the answer generally is each period of remission is less than the one before, unfortunately. So your best remission is your first remission, generally. Now, what's countering that is that's assuming all therapies are equal in the treatment landscape is stable, which is not true in CLL. So if you had a short remission, let's say with bendamustine and rituximab, because that's all that was around, or that's what your doctor used, and then later, and let's say you got 18 months out of that, or let's say you had 17p and you got nothing out of that, and then you go on ibrutinib or acala, you're going to do way better because you're using a newer therapy. But if all therapies are staying the same, generally your first remission is your best remission. That's changing in CLL because the treatment landscape is changing and we're getting better and better therapies right now. So I saw you kind of, your eyes roll a little bit when I said that. But there is a reality to this, and this is CLL is not a solved problem, and this is why we're pushing for research, and this is why we're pushing so hard at the FDA, who say, well, you got ibrutinib and acalabrutinib and zanubrutinib is on its way, and you got venetoclax. Essentially, we have two classes of drugs, and we can add really good antibodies to those two classes of drugs. But when you fail those two classes of drugs, you don't have a lot of choices. You have clinical trials. So you want to be thinking about these things, in terms of what you do, and try to, sequence your therapy. Think of it like a chess game. What's this move? What's the next move? Because the odds are, except for a transplant, you really got to think of all therapies in CLL as palliative, that they buy you time to get you to the next therapy. But I had a transplant, didn't work for me, but it got me to ibrutinib. The ibrutinib then got me to CAR T. CAR T will get me to the next thing. That's the way you do it. You just keep kicking the can down the road, and hopefully you get enough time, and the scientists are smart enough, and the FDA doesn't give us enough trouble, that we get these things approved and ready to go.
Someone was asking if they've relapsed. Now, they didn't say if this is their first time to relapse, but if they've relapsed, and you best can answer this, should they go on CAR T? They didn't give any other specifics.
So I think for anybody who's, I think CAR T is a great therapy, and obviously I chose it for myself. So I think when you have two great classes of drugs, we have the BTK inhibitors, and we have a new one coming, pirtobrutinib, which looks really promising. And we have venetoclax, and we have new drugs being developed that are like venetoclax, that have really high response rates. You should really consider those, and run through those first in combinations and those things. But if you've done that, then I think looking at CAR T makes a lot of sense. But you may also want to look at bispecific antibodies, which are in development, or neurodegraders, which are in development, or Syk inhibitors, and there's all kinds of new drugs that people are looking at that you may want to look at. You can hear, and we also have PI3 kinase inhibitors. At least we have them for now. That's another option that you can be using. And we have high dose methylprednisolone, which is an old therapy that can be used. So we do have other, and there's still transplants for some people. So, you should be looking, but CAR T should be high on your list. What I love about it is it's the ultimate one and done therapy. Dr. Siddiqui, who does a lot of CAR T therapy, says, give me a month of your life. You may be miserable for a few weeks of that month, but at the end of that time, I'm going to check your bone marrow. I'm going to scan you. I'm going to do blood tests. And there's an excellent chance we won't find any CLL. And you're going to have a really long glide. So I think most it's the ultimate kind of one and done therapy. It's just, you get it and it works or it doesn't work. And in a month, the most 90 days, kind of, whether it's going to work or not.
And is CAR T still have in the unsuccessful category, there's still a danger of mortality if you opt to try CAR T, or is it not as unsafe as it was in the past?
So CAR T is much safer than a transplant, for example, where transplant-related mortality is still in the high teens, for people, for a lot of people, where CAR T numbers are low single digits. There are people who die of CAR T therapy, but it's extraordinarily rare. In the trial that I was in, there was 40 patients. There was 2 deaths. One was a late death, and the other was probably an irregular heartbeat related to the ibrutinib that patient was on, and probably, the CAR T may have been a factor in that, but it was probably not directly the CAR T. CAR T has a very low mortality rate. It has a very high morbidity rate, which means you feel morbid, you feel horrible. People get fever, chills, flu. But the new CAR Ts that are coming out, I was just talking to a friend about CAR T. He had a little achy fever, a little flu-like, didn't have to be hospitalized. A lot of CAR Ts now are switching towards outpatient therapy. So that tells you that it's pretty safe. It's doing pretty well.
That's fantastic to hear.
Yeah, I think CAR Ts are part of the future, but there's no approved CAR Ts at this point, so you have to enter a clinical trial to get them.
All right, so here we have someone asking, hold on, about drugs in the pipeline that we should be aware of that might change the landscape of, this is for speaking about all this, that might change the landscape of CLL treatment in the near future.
So let me talk about 3 classes of drugs here. The first one that I think is, there's a drug that's coming to CLL. It's already, you can use off-label, and it's zanubrutinib. And it's another BTK inhibitor, and it has, it's like ibrutinib and acalabrutinib in terms of its efficacy. There's some hints that it might be more efficacious, but that's really not proven, at least to my mind's eye, but it certainly is at least equal and maybe better. And it has very few side effects. So that's exciting, and that is probably going to be approved relatively soon. But it's not a big change. Pirtobrutinib is probably next in line. And what's different about it is the way it binds to the BTK. It blocks the Bruton tyrosine kinase inhibitors, but it blocks it in a non-covalent or reversible way. And therefore, for a lot of people who are resistant to BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib, pirtobrutinib will work. The good news is it also works for people who have wild type or normal, aren't resistant to those. It also works just as well. It also works in 17p deletion, and it seems to be a very clean drug with very few side effects. So how it's going to fit in, whether it's going to be used frontline, whether it's going to be used in relapse, we don't know yet, but it's going to be a very valuable and important drug to use, and it's probably next in line. The other 2 drugs I'm going to talk about are a whole different model. The way we get rid of BTK and also the way we get rid of BCL2 is by inhibiting them. We block BTK with drugs like ibrutinib, acalabrutinib, and zanubrutinib, and we block BCL2 with venetoclax. There's a class of drugs that called degraders, and it's exactly what the name says. They tag these chemicals for this cellular mechanisms to say, oh, this is a crappy molecule here. And they degrade it, they chew it up and eat up the BTK. So they don't block it by binding to it, they actually destroy it. They also eat it up, so it's gone. So these are in development. They're very promising. They've been studied at the NIH for years, and there's clinical trials open, and they're working they're more advanced from what I understand in BTK, but they're also working on BCL2 as a replacement or an alternative to venetoclax. The last thing that I'll talk about is bispecifics. And bispecifics are antibody. So an antibody is like Y-shaped, and normally both prongs have the same attachment, and they attach to the cancer cell. But what bispecifics do is that they attach, one part attaches to the cancer cell, and the other part attaches to the T cells. And then they bring these two together so the T cell doesn't have to travel or be smart or do anything, or if it's exhausted, it doesn't care. The bispecifics have brought those two together so the T cell kills off the cancer cell. So these have been used very successfully in other lymphomas, and they're just starting to open up in CLL. There are we know about the BTK pathway, there's SYK pathway, there's other pathways, the PI3 kinase pathways. So there's all new molecules being developed. I'll just share one other thing. There's a new PI3 kinase inhibitor that's being developed where you're on the medicine just for a few days each month, and then you're on a drug holiday. This is after a loading dose for a couple months. And that seems to significantly lower the risk of these autoimmune complications with the PI3 kinase inhibitors, this intermittent dosing that then allows you to be able to take it long term. It doesn't seem to affect the efficacy of it. So there's new things being developed here. So yeah. So wow. Yeah.
So, so a follow-up question on this. So with pirtobrutinib, and would that also be indefinite duration therapy, or is that yet to be
so
seen?
I think the guidelines on pirtobrutinib would be the same. It would be take until intolerance, which doesn't seem to be much of an issue, or disease progression. So it would be, essentially you take it until it stops working or you can't take it anymore. Yeah. Okay.
And let's see, I think we have time for one or two more questions, or let's see what we're doing on time here. Ibrutinib
we're
and
over, but yeah.
Oh gosh, yeah, I just looked
I'm
at
good.
the clock. Time flies, huh? So ibrutinib and venetoclax, that trial, we heard at the conferences, it's hopeful that it'll be approved soon. Any idea on when that would be for the US FDA for approval?
Well, it was recently approved in Europe, which is exciting. The only thing, trying to know what the FDA is doing is like trying to know what the Fed is doing or what the Supreme Court is doing. I mean, it's a fool's game to try to predict what they're going to do. But I think it'll be sooner rather than later. I think that it'll be sooner rather than later. How it's used, what's going on, it's whether it's better to sequence or do things in parallel. We don't have great answers for that, but it's certainly a potent combination. And I think people with aggressive disease, deletion 17p or TP53, should really be looking at it. Okay. Did you have one more, or should we get to closing? Or I'm willing to keep going, but I'm sensitive to people's time.
I know this one will be rather quick. We've had someone patiently awaiting an answer on if a patient has Epstein-Barr virus antibodies. What are your thoughts on treating the Epstein-Barr? Is that a root cause of CLL?
So while Epstein-Barr virus has been associated with other cancers, the relationship with CLL has not been established. I think that treating it would I think you want to treat any infection you have with CLL. Cancer is an inflammatory state. Infections are an inflammatory state. CLL patients generally don't die of their CLL. They die of infections. They die of second cancers. They die of heart disease. We have a higher incidence of heart disease because heart is an inflammatory process too. So anything to calm inflammation is good. But specifically treating EBV, Epstein-Barr virus, I don't think that there's the relationship like there are with some other cancers. So no, I don't think that's an issue. Yeah.
And we have a question from Terry Evans. Can you
Okay.
explain using immunoglobulin gene rearrangement bone marrow test to determine MRD status?
Well, I think they're sequencing your immune globulins to see what clone you have. And they know what clone maybe was there, and they're looking for a clonal pattern consistent with your CLL. If there's a clone that's recurrent, that's what my understanding is. That's what they're sequencing to see. You had this when you had a lot of CLL. Now you hardly have any. We can't see it by flow cytometry anymore. But maybe if we look at the immune globulin and we have a sequence that's hundreds of nucleotides long, and we see, oh, there's a lot of it there, then maybe you still have, 15 in a million CLL cells. I think that's what's going on, but you're getting a little bit above my pay grade there, Terry, on that one.
I knew he'd have someone that would, he's trying to stump you, I think.
Yeah. Terry asks me stumping questions all the time. Terry heads all our support groups in the local Orange County group. Yeah.
I know. That's why I thought he'd have a great one here. Okay, another one about BTK inhibitors and heart and sudden heart attacks or scarring of the heart.
Well, I don't know about scarring of the heart, but I do know it is all the BTK inhibitors are associated with atrial fibrillation. But whether that is, but ibrutinib clearly has a higher incidence of atrial fibrillation. It also has a higher incidence of hypertension, and that the hypertension accumulates over time. So unlike the infections we talked about, which get better after the first year, hypertension continues to climb in the second, third, fourth, fifth year. It continues to go up. CLL is a disease of older people, and there's more atrial fib. So there's some thought that with zanubrutinib, acalabrutinib, and pirtobrutinib, the atrial fib may be similar to background noise of that age group. But with ibrutinib, it's clearly there. It's less clearly there, but there is atrial fib with the others. There is other more serious arrhythmias. So when the atrium, which are the small chambers of the heart, don't function normally, that has some dangerous effects, but you don't drop dead. If your ventricles, which are the big pumping, the pump into the aorta, your left ventricle, if it starts fibrillating, that's a cardiac arrest. And that's where they get the defibrillators, the paddles, stand back. You see on the ER, and they whoop, and they zap you to get your, to reboot your heart, right? That's not compatible with living more than 2 or 3 minutes, so that's the sudden death. And there have been some suggestions that we see more of that with CLL patients on ibrutinib. So, but it is rare, but there is some suggestion that it may be there, but it's extremely rare, but it does happen. I'm not being dismissive. There are these ventricular events that have been associated. I've seen less about that with acalabrutinib and zanubrutinib. I don't know if they occur with them or not, but I know with ibrutinib, there's been papers published that suggest there's a higher incidence of these events. But all drugs have side effects. People drop dead taking penicillin or aspirin, so I'm not trying to diminish it. I think it's something that you have to consider, but there is risk with all of these things.
I feel we haven't touched on venetoclax much. One question which kind of combines a lot of questions. If someone is on venetoclax or venetoclax combination therapy in combination with something else, if a patient reaches UMRD, should they stay, in your opinion, should they stay on venetoclax or come off of it if it's okay, and if they're on a trial or on their own treatment plan?
So I'm glad you said, in my opinion, a great question. I think one of the big advantages to venetoclax is if you get to UMRD, and you might want to confirm that with a second UMRD, maybe 3 months later, that you should probably stop it and glide and see, because you can probably retreat. And there was a paper published at ASH that showed people who took venetoclax for less than 2 years did not develop mutations that led to resistance to venetoclax. So another reason to try to keep your time under 2 years. People did develop those mutations after 3 years and more. So another reason to try to get off of it.
Okay, this has been great.
Yeah, I think it's time to close up. You know, I have, you know, I'm going to let you say the absolute final words, but I have some closing thoughts. Here, just there's an event survey that I'm going to ask people to look at. It's pinned in the comments. Please look at that. Later this month, July 23rd, we're hosting our first virtual 5K run event. We're not going to have a tape measure and assure that you actually complete the 5 kilometers. It is, but try to make it fun. It's a virtual event. If you want to do it on your own, we have ways to help you get sponsors for it. If you want to do it with a group of other people and socially distance, whatever you feel comfortable with, but please support us on this. We're very excited. August 2nd, Dr. Mazar Shadman, he's one of the doctors that took care of me at the Fred Hutch when I had my CAR T therapy. He is a great educator, and he's going to be talking on CAR T therapy, so we'll be able to dig into that deeply. We know that we didn't get to all the questions, but send them into our Ask the Experts email service, and the webpage for that will be provided in the chat. And please remember, the CLL Society is a nonprofit. It's invested in your long life. And if you can invest in the long life of the CLL Society by supporting our work, we're extraordinarily grateful. So be strong, stay strong. We're all in this together. Thank you. Thank you to everyone who asked such great questions. Thanks to the team for handling the IT, and big thanks to you, Michele, for making me feel so comfortable in doing this Facebook Live. And I'll let you close it out.
Well, thank you. This has been a true pleasure for me and an honor. So thank you for inviting me to be part of your event. The CLL Society is such an important part of our CLL community. And it's just, every year you grow in all that you're offering to patients, and it's wonderful. And I commend you for it. I look forward to joining you again. Let's do this again sometime.
Let's do it again. All right. Good. Thanks,
Okay.
everyone. Have a great day.
Thank you.
Bye-bye now.